All right, today I want to talk to you about Mycobacterium. We're going a little bit out of order here. I thought it might be easier to deliver this talk on Mycobacterium this way. Wednesday we'll do the gram-positive bacilli like Clostridium and tetanus, botulism, anthrax, that kind of good stuff. But I just thought it might be easier to talk about Mycobacterium this way. Of course, we did the gram-positive cocci last week, the Staphylococcus, the Streptococcus. Mycobacterium is not really considered gram-positive, even though this material is included under Chapter 19, gram-positive organisms. But we don't really consider Mycobacterium gram-positive. It's true that it doesn't have an outer cell membrane like the gram-negatives, so that's why they put it here. But really, Mycobacterium is a class by itself. We consider these acid-fast organisms. Little lab review. Remember that when we're staining acid-fast organisms, that they hold fast to that primary dye, carbylfusion, even when they're washed in acid alcohol. All right, so that's why we call them acid-fast. Don't confuse Mycobacterium with the Mycoplasma. That's a genera of organisms that we've mentioned a few times. Those are organisms that don't have a cell wall. So when we describe their morphology, we describe them as pleomorphic, meaning they don't have a shape. All right, but Mycobacterium, acid-fast, there's about 75 species known. Some of them are environmental, some of them cause disease in other mammals or birds, but we're going to be focusing mostly on Mycobacterium tuberculosis. I mentioned Mycobacterium leprae. That's the causative agent of leprosy, which has been, a scourge of mankind since ancient times. It's a disease of the nerve endings that causes a lot of disfigurement. But we're going to spend most of our time here on Mycobacterium tuberculosis. But all these organisms, what they have in common is this acid-fast cell wall. And of course, what makes those special is that they do have peptidoglycan, just like the gram-positives and gram-negatives, but they also have this thick layer of mycolic acid, which is a lipid, and we describe that as having a very waxy appearance, a waxy feel. So when we try to stain these acid-fast organisms with, say, gram-staining dyes that are water-based, what do you know about oil and water? They don't mix. So those stains just don't penetrate the cell wall very well. So we've needed a whole different staining process to be able to see these cells. All right, but those acid-fast cell walls does confer some advantages to the organism, makes them very resistant to digestion within a phagolysosome. So say a macrophage phagocytizes them. They have a good chance of survival within that macrophage. When they're out in the environment, they're very resistant to drying out, to in any kind of environmental thing that might harm them, like some chemical disinfectant or acidic conditions. They're resistant to a lot of antibiotics, again, just that impermeable to a lot of different things. And they grow really slowly, which probably isn't an advantage to them, but it takes the cell a long time to synthesize that mycolic acid. So they do grow slowly. That's another reason that a lot of antibiotics don't work well on them, because we know that cells have to be actively growing for a lot of antibiotics to work, especially the beta-lactams that interfere with the growth of that cell wall. All right, so they do grow slow. The Mycobacterium tuberculosis, for example, when we grow that up in the lab, it takes the colonies about 6 weeks to form. So really slow growth also means it's harder to kill them as well. Some other virulence factors, your book doesn't get too specific here, and the more I read about this, the more I understood that that's just because it's incredibly complicated. So I'd say read more about it if you're interested, but we're going to kind of keep it to a introductory microbiology level here. There is a particular virulence factor that, again, only Mycobacterium tuberculosis has that we refer to as cord factor. And cord factor is actually part of the acid-fast cell wall. It's a glycolipid. And we know the organisms that are mutant for cord factor, that don't have cord factor in them, we know they're avirulent. So they don't cause disease if they don't have cord factor. So this is an extremely important virulence factor. We know that the cord factor is the reason that the cells tend to arrange the way they do. They tend to kind of stick together, and these are rod-shaped, bacilli organisms. They kind of stick together and form this cording pattern. We know that it's extremely necessary to inhibit the fusion of those lysosomes with the phagosomes when the organism is phagocytized by a macrophage. So actually, Mycobacterium tuberculosis is an intracellular pathogen, just like viruses. They actually are enveloped by that macrophage and then live quite contentedly within macrophages. We do know that when they're extracellular, that cord factor in the cell wall does have some impact on our innate immunity, inhibits the migration of neutrophils, so they're not going to chemotax and towards the invading organism as well. So that cord factor, again, extremely important virulence factor. We know there are other virulence factors that help the organism survive within those macrophages. Once the phagosome envelops the organism, there are virulence factors that cause certain proteins within the macrophage not to function properly, ones that would pump in hydrogen ions that would acidify the phagosome. Other factors, again, this gets pretty complicated, that keep the lysosomes fusing with the phagosomes. And also macrophage activation. Remember, when macrophages are activated, they get bigger and they get better at killing organisms. So the Mycobacterium tuberculosis can actually prevent that activation in some cases. So gives it a better chance of surviving inside that macrophage. All right, if we look at how the disease of tuberculosis progresses, it's a pretty complicated disease, as I think that you'll see. But it always, although it can eventually infect lots of different parts of your body, it always is going to begin in the lungs. So a patient will inhale the tuberculosis bacilli, and it will start out in the alveoli. So the distalmost portions of those bronchial tubes in our lungs. And it turns out we have lots of macrophages in our alveoli. All right, so the bacilli get engulfed by the alveolar macrophages. And those virulence factors, like cord factor, the mycolic acid in the cell wall, enable the bacilli to replicate freely in the macrophages. So remember, this is like the criminal hiding out in the police station, right? The very cells that are supposed to kill it is where they actually live and proliferate. All right, so at this stage of the illness, this is going to cause mild flu-like symptoms when we've got that bacilli that's been inhaled, typically for a week or two. So some fever, some discomfort. At this point, one of two things happens. Either our immune system wins. We get good T-cell, B-cell activation. Remember, it's those cytotoxic T cells that go after the intracellular pathogens. The macrophages activate At this point, in most cases, we think our immune system wins after this initial exposure. But in about 10% of the cases, the immune system doesn't win. It comes to more of what we might call a stalemate. And in this case, if the immune system doesn't win, we get the formation of tubercles. So this is where the name tuberculosis came from. You can call them tubercles, you can call them granulomas. But this is where we get some infected macrophages here that are surrounded by lots of dead macrophages that have been killed by the bacilli. You get some collagen formation here, and basically the immune system is able to wall off the infection, but not totally get rid of it. There's a lot of dead macrophages, dead cells here, but there's also some living ones. But the living ones really don't have the oxygen or the nutrients they need to proliferate. So again, this represents the tubercle as kind of a stalemate between our immune system and the bacilli. And the patient is actually not infectious in this case. This is considered primary TB. The patient can have these tubercles for years and years and years, and nothing may change. The patient could have these for the rest of their life. In some cases, we get this caseous necrosis. So necrosis means death of tissue. A caseous necrosis, this is a special kind of cell death where the cells actually turn into this sort of cheese-like consistency. It sounds kind of gross. But the inside of the tubercle kind of gets super runny, and eventually the tubercle will rupture. Okay, so then once we have the ruptured tubercle, then we get reactivated TB. So we think about 10% of the people that have primary TB, eventually those tubercles will rupture. Now you have an active infection. The patient is going to be basically coughing out these bacilli pretty frequently and able to infect other people. So with early symptoms here, we see coughing, obviously, chest pain, sometimes blood in the sputum. As the infection progresses, we get things like fever, chills, weight loss, paleness. That's why this disease used to be referred to as the White Death. And in fact, for a while in the 1800s, this was a real popular thing to have this ghostly-like pallor. There was famous poets that had tuberculosis, and they thought they were really cool. But patients were really tired. That's where the name consumption came from. It's a disease that tends to consume the patient. Without treatment, mostly patients would die if it progresses to secondary TB. And then in a lot of patients then that would move into third stage, or what we refer to here. And with the disseminated TB, this is now that the infection has moved outside of the lungs into lots of different parts of the body. Kidney function is lost, problems with bones, meningitis even. It's getting into the bloodstream and moving into all parts of the body. And this is going to be 100% fatal without treatment. And even now with good medical treatment, very high mortality rate when it gets to this stage of TB. So part of the trouble with the disease is that it's difficult to diagnose. So we have, just because there's latent stages and active stages, and if you've been vaccinated, that throws a whole nother wrench into it. So typically the first step in diagnosis is a tuberculin skin test. And most of you have had these, especially if you have a job in healthcare. But you go to the doctor and they'll inject a little of this tuberculin protein under the skin, and then you have to go back a couple days later and see if you have a delayed type hypersensitivity reaction, so redness and swelling where that protein was injected. If you do, that means one of several things. Either you've been vaccinated, either you have primary TB or have had it and your body cleared the infection, or you have an active case of TB. So it could be any of those things. So that's just the first step. A little bit newer, we have a TB blood test that's called an interferon gamma release assay. So again, this hasn't been available for too long, but they're thinking now that this might be a better way to test for TB, because with the interferon gamma release assay, this will not test positive simply because you've been vaccinated. So that's a plus. They're not sure that these work as well with children. But the premise that these work on is that if your T cells in your blood sample recognize, if you have T cells that recognize a TB antigen, then when those T cells in your blood sample have been exposed to the TB antigen, they'll release interferon gamma. We didn't talk very much about interferon gamma, but that's a cytokine that's released by T cells that activates macrophages. All right, and of course we know that macrophage activation is a really important defense against TB. All right, so if you have T cells, meaning you have memory T cells that recognize the TB antigen, then you'll have a positive blood test, which means either you have primary TB or you've had primary TB and again your body cleared the infection, or you have active TB. So at least the advantage with the TB blood test is that it's not positive just because you've been vaccinated. But if you're positive for the TB blood test, then they need to know, well, do you have an active case or what's going on? They'll typically do a chest x-ray to look for tubercules. If you have tubercules lower in the lungs, then that tends to mean you have primary TB, meaning the dormant form of TB. The higher they get in the lungs, then that's more likely that you have an active case of TB. And how they tell the difference between pneumonia and tubercles and all that, I don't really know. But if you had primary TB and your immune system cleared it, then you won't have any tubercles or any lesions at all. So the chest x-ray is to kind of clear those people. If you've got tubercles, then they need to know, well, is this active or dormant TB? And they'll typically do a sputum sample and either do an acid-fast stain or more likely some kind of immunofluorescence, because with the immunofluorescence they can tag a fluorescent antibody for mycolic acid, and then when you stain a sputum sample, of course there's going to be all sorts of different cells in there, but only the TB ones will test positive, will fluoresce, and you can just see those really clearly. So this is really the definitive diagnosis, the sputum sample. So it's kind of a rigmarole to get to that point, though. All right, let's look at the epidemiology here of tuberculosis. If you think about TB, you probably think, well, that's something that we have other places and we don't have in the United States. And actually, the incidence is quite low in the United States. If you look here at our next figure, in the U.S., we're hitting around 10,000 cases a year right now. You can see that peaked late 80s, early 90s during the AIDS epidemic, and we're getting less and less now. But worldwide, this is a huge problem. Just because we don't have it here very much doesn't mean that we won't. It's estimated that about a third of the world's population is infected with TB, which is astonishing. But Remember, most of those people probably have the dormant form of latent TB, and that might not ever progress into the active form. But you can see here sub-Saharan Africa is a place where we've got a huge TB problem. It's no coincidence that that's where we have a huge problem with HIV as well. So this is a huge population of people that are dying of tuberculosis, ones that also are infected with HIV. Humans are the only reservoir, so we thought in the late 50s that we were going to easily be able to eradicate tuberculosis. As you can see, that's not been the case. About 1.5 million people die worldwide of TB every year. That's pretty much what we're holding at. So it's made a huge resurgence, not just because of AIDS, but because of drug-resistant strains that are showing up as well. This is an airborne transmission. It's not nearly as infectious as something like smallpox or measles. Remember, only about 10% of people that are exposed even get, that first little active flu-like symptoms. So for some reason, it's not terribly transmissible, even though it is airborne. What are some predisposing factors that if you are exposed, you would actually come down with a case of TB? HIV is a big one. Anything that's going to damage the cilia action in your lungs that would work to dispel pathogens, anything like smoking is a big predisposing factor. Anything that would kind of make you immune compromised, drug use, alcoholism, poor health care. Certain populations are just a little perhaps more susceptible genetically. So, okay. Let's see, we talked about that. Well, what about treatment? Treatment is complicated. The first TB drug, the first antibiotic that came out that was effective against TB was streptomycin. Clinical trials finished for that in 1946. And this was hailed as a wonder drug. But it pretty soon began losing effectiveness after that. And in fact, now when a patient is diagnosed with tuberculosis, they're always given a combination of drugs to try to slow down the rates of resistance. So we've talked about some of these drugs. These are typically the 4 drugs that would be given if a patient has sort of garden variety non-resistant TB. Isoniazid is a mycolic acid inhibitor. We talked about that one before. Rifampin, that's the one that turns your pee orange. That one is a RNA polymerase inhibitor. Pyrazanamide, we don't know the exact mechanism of pyrazanamide. It does slow down shortened therapy time, so that we know that when we add that drug, you don't have to use the other drugs as much. It might have something to do with inhibiting membrane transport of proteins there. And lastly, ethambutol. That inhibits the incorporation of mycolic acid into the cell wall. So typically patients are given all 4 of those drugs for 2 months and then isoniazid and rifampin for additional 4 months. So patients are on these drugs for at least 6 months, and the problem is side effects are really common. So they've got this huge cocktail of drugs that they're taking every day, and these drugs are giving them headaches, giving patients, making them feel nauseous, making them feel tired. So they're drugs that are not fun to be on. So once people start feeling better after a couple months, it's common for them to quit taking them. So they have special programs where they send a healthcare worker to homes and actually watch people take their drugs just to keep them from taking them. Because if you get, if you don't clear all these organisms, remember it takes them a long time to be killed, then it can come back. And it will likely come back in a form that's resistant to these drugs. We know that about 10% of all new cases of TB are multiple drug resistant. So MDR strains are ones that are resistant to this first line of antibiotics. So they typically switch to using things like kanamycin, which is another which is an aminoglycoside like streptomycin. Fluoroquinolines, which inhibit DNA gyrase. Remember, those have some more serious side effects, or they can. Streptomycin, and typically streptomycin is not used unless these other first-line drugs don't work. All right, and patients are typically on those drugs for 12 months, even 18 months. And then there are strains that are considered extensively drug-resistant, XDR, 1 to 3% of new cases, and for those patients, basically nothing works, and we're out of treatment options. Now, a couple years ago, we did, the FDA did approve the first drug in 50 years with a novel mechanism to work against TB. Bedaquiline actually interferes with mycobacterial ATP synthase. And that drug, again, is used in combination with other drugs, hopefully to kind of slow down the resistance there. All right, so treatment is a drag. What about preventing TB altogether with a vaccine? Well, we have a vaccine, but unfortunately, it's not a very good one. My apologies to the 3 French guys that came up with it, Bacille, Calmette, and Guerin. So our vaccine is referred to as the BCG vaccine against tuberculosis. This is actually an attenuated vaccine, meaning it's actually a weakened strain of Mycobacterium bovis. So that's a strain of tuberculosis in cows that's actually been grown up in culture over many, many generations, so that it's kind of lost some essential virulence factors and doesn't cause disease. We don't know exactly, what's different about it, though. It's not terribly effective, up to 80% effective in children, a little bit less so in adults, lasts between 5 and 15 years. We don't typically inoculate children or adults in this country unless they've been exposed to somebody or live with somebody that has active TB. Primarily because, remember, once you're vaccinated, then you test positive for the tuberculin skin test, so it just complicates figuring out if a patient has TB or doesn't have TB. So in this country, it's not, part of the normal repertoire of childhood vaccinations, but in other countries, it is used more often, but it's just not 100% effective. All right. So if you have questions about TB, definitely ask on Wednesday or later on this week. And we will see you soon.